Thank you for joining us. Today, I'm going to show you a series of videos that discuss the management of cholesteatoma. First, I'm going to show you a video of a discrete attic cholesteatoma resection using the posterior tympanotomy as well as a transcanal exposure, ending up with a nice intact canal wall reconstruction. Then I'm going to show you the second stage reconstruction that uses the posterior tympanotomy as the route to place a PORP, or partial ossicular reconstruction prosthesis. Now after that, we're going to see a video that was from a much more extensive cholesteatoma that had extensive involvement of the meso and hypotympanum. And in this case, you will see the reconstruction and second look that also takes advantage of the posterior tympanotomy, but adds the use of an endoscope in order to get a very nice view into the hypotympanum and to the eustachian tube orifice area so that we can make sure there's no recurrence. And the endoscope also lets us check the position of the PORP. Finally, I will show you a video where the posterior tympanotomy is used to perform an incus interposition. All right, let's get started. In this video, I'm going to demonstrate a fairly standard approach for the removal of an attic cholesteatoma. When performing ear microscopy, it is very important to examine the upper attic region. Here you can see a polyp, and the polyp generally represents granulation or inflammatory tissue emitting from the neck or the opening of the sac of the cholesteatoma. Now I'm looking more inferiorly to assess the status of the remainder of the tympanic membrane. In this case, it is intact, and that is very helpful for the reconstruction. Now I am injecting a 1 in 100,000 diluted epinephrine to allow for hemostasis, and notice that I milk it down the ear canal by use of the ear speculum. We inject in multiple points around the external auditory canal to deliver the hemostatic agent. Because in this case I anticipate that the attic bony defect is going to be fairly limited, I'm going to harvest tragal cartilage and perichondrium at the outset. The incision is hidden and the tragal tip is preserved to avoid the resultant cosmetic defect if not done so. The plane of dissection is between the skin and the tragal perichondrium. I am widely exposing this area in order to get the largest portion of tragal cartilage as possible. Once I have judged the dissection to be adequate, I sharply cut with a 6500 beaver blade completely through and through the cartilage and perichondrium on the contralateral side. Then, using a small duckbill, I develop the plane between the perichondrium and the cartilage and dissect widely. When grasping to remove the cartilage, it is important to use a blunt pickup as not to penetrate or damage it with a sharp tooth. The wound is then closed with absorbable 5-0 gut sutures. I make a post-auricular incision from the mastoid tip and then up atop the pinna with a fine needle tip monopolar cautery. I go down straight to bone towards the mastoid tip, and then putting a finger in the ear canal to feel the position, I cut straight down just at the temporal line, and then a little back cut to get good exposure. Using a dry gauze, I elevate the soft tissue to expose the back end of the external auditory canal. I then undercut the temporalis muscle so a second retractor can be put in place, because a good mastoidectomy must cover the territory superior to the external auditory canal to properly access the attic region. At this point, I am bluntly elevating the skin of the external auditory canal to get a good view of the position of the canal wall to perform an intact canal wall mastoidectomy. I begin very anteriorly and superiorly to identify the position of the temporal dura, keeping the bone intact, and then work inferiorly towards the tip to identify the position of the external auditory canal. We will go through Kerner's septum, taking great care and attention to follow the position of the tegmen and the temporal dura, keeping the bone intact, as well as identifying the position of the sigmoid sinus. Thinning the external auditory canal wall is extremely important in achieving a good posterior tympanotomy, the first step there being to open up the inferior air cell tract down towards the mastoid tip. I have switched over to a diamond burr to follow the tegmen carefully and open up the epitympanic region in order to access the attic cholesteatoma. At this point, you can see that the cholesteatoma has broken through back into the mastoid cavity. It has also destroyed much of the incus. It is very important when dissecting the matrix to try to preserve it and keep it intact so that you can follow it as a tract to not leave any residual portions. The epitympanic region still requires further dissection, but I will do this in stages and follow the matrix so as not to disrupt it, carefully dissecting it free from its bony attachments. Now I am elevating the matrix off of the lateral semicircular canal, which is going to serve as an important landmark for the formation of a good posterior tympanotomy. At this point in the procedure, I'm going to identify the facial nerve, thin the canal wall, and widely open the posterior tympanotomy in order to gain direct access to the incutostupedial joint. Here you can see the beginning of the facial recess air cells and the facial nerve identified. It is very important to maintain copious and constant irrigation as to not heat the region of the facial nerve. At this point, we are beginning to see the chordotympani nerve, which is an excellent landmark because it passes just medial to the tympanic annulus. Using a curved Rosa needle, you can pick at the air cells and define the exact extent of the posterior canal wall to not penetrate it. It is safer to use a larger diamond burr to identify the facial nerve, but at this point, once I know its location, I'm going to change to a smaller burr to be able to safely enter the posterior tympanotomy, as well as expand the epitympanic dissection to gain further access to the cholesteatoma matrix. Now I am going to enter the posterior tympanotomy and disarticulate the remainder of the incutostapedial joint. This will minimize any acoustic trauma from drilling onto any remnant of the incus. A gentle curette can be used effectively to avoid traumatizing and disrupting the plane of the matrix, which must be carefully kept preserved and intact in order to optimize the complete removal of a cholesteatoma. With the posterior tympanotomy widely open, I can safely clear the oval window and horizontal facial nerve region. At this point, I will complete the dissection of the epitympanic region, keeping the canal wall intact and working from the mastoid side. You can see here how I am carefully dissecting the intact matrix from the adjacent bony structures. The head of the malleus is blocking access to the remainder of the cholesteatoma, so needs to be removed. I will complete as much of the dissection through this route prior to opening and entering through the external auditory canal skin, and then work in a combined transmastoid and transcanal fashion to ensure complete resection of the cholesteatoma. I will elevate now the remainder of the external auditory canal skin and then make incisions to create a Kerner's style flap, and then move it forwards with a bladed retractor to get a good view of the attic region. I am smoothing down the spine of Henle in order to get optimal view and working space transcanal. Prior to entering the external auditory canal, however, I'm going to carefully incise and elevate the communication between the tympanic ring and the temporal bone, and then perform a limited anterior canalplasty so that I could get ample access to the anterior superior extent of the tympanic membrane's communication with the cholesteatoma neck. I am using a 2mm diamond burr and removing the anterior aspect of the tympanic bone to make it flush with the scutal area and the anterior aspect of the external auditory canal bony wall. There is a fair amount of soft tissue that can be removed, and sequentially smaller burrs can be used to adequately perform this. At this point, I will incise and create a Kerner's flap using a combination of a sharp 6500 beaver blade and a Bellucci style microscissor. Again, note the importance of performing the superior incision in a very anterior fashion. I prefer the use of a bladed Perkins-style retractor to move all of the tissue anteriorly to get a good view of the anterior canal wall skin, and then make an incision on the anterior superior aspect and create a small flap that can be down elevated and then replaced to cover up the cartilage graft during the reconstruction. This is particularly important because we want to gain access to the anterior superior annular ligament and raise it up in order to get a good underlay in that region. This is particularly important as well so that I can use a small diamond burr to just gently remove some of the scutum bone to get access to the anterior superior attic region, which is an area of high rate of recurrence if not performed properly. You can see the neck of the cholesteatoma has been exposed, and now I am elevating the posterior superior annular ligament to get good wide access to the middle ear and also to incise the chorda tympani nerve, which must be removed because it is enveloped in cholesteatoma. You can see that cholesteatoma has involved a portion of the undersurface of the tympanic membrane, and I will excise and remove this segment to ensure the minimal chance of recurrence. Here I am once again using the malleus nipper to separate the malleus just distal to its attachment to the tensor tympani tendon so that the tympanic membrane remnant is one intact portion separated from the cholesteatoma and neck. And now you can see, using a gentle curved Rosen needle, that I am dissecting the anterior superior aspect of the annular ligament and separating it cleanly so that everything inferiorly will remain during the reconstruction, and then everything superior to this region will be completely excised and removed. Now I will remove the remainder of the disease and clean up with a diamond burr all the bony contact points. Using a curette, I will explore around the medial canal wall edge to make sure that any remaining keratin fragments are removed. Using a diamond burr, I will take down the petrosquamous stalactite and then explore the sinodural angle, because these are two major regions of recurrence from hidden cholesteatoma that can trap underneath unvisualized regions. Now I am taking down the knuckle of bone to smooth it to the level of the lateral semicircular canal to facilitate the view during the second stage reconstruction. With a duckbill elevator, I am gently elevating the anterior superior annulus so that I can get a good underlay graft. I am also exploring this region carefully to make sure that there is no retained shedded keratin debris. I am introducing a small piece of umbilical tape gauze and scraping it along the medial canal wall edge to help ensure that there are no more cholesteatoma fragments remaining. For the reconstruction, I am going to use a combination of thin-cut tragal cartilage as well as an underlay graft of tragal perichondrium, which I am now separating from the harvested cartilage. It is important to keep this moist during the procedure, as if it is allowed to dry out, it can sometimes be very difficult to cleanly separate. I place a 0.3 millimeter shim in a Kurtz-style cartilage cutter and then slice the cartilage in half under direct visualization with the microscope. Using this method, you can usually get two nice thin pieces of cartilage to choose from, or sometimes use them both if necessary. Note the shape of the thick silicone that will be implanted into the middle ear and then removed during the second look reconstruction. It is fashioned so that it stabilizes the cartilage graft and has a point to introduce into the eustachian tube region. First, I have placed the cartilage graft, and now I am using the perichondrium to reinforce the reconstruction. This serves as a very strong and stable reconstruction to prevent further reformation and re-retraction. This construct will also support the prosthetic that will be placed in the second look and ossiculoplasty phase in order to minimize extrusion. I have also rotated the flap that we created earlier over the cartilage graft, and I'm now packing the external auditory canal with absorbable material to hold things into proper position. Then I will place additional gelatin-based packing material through the mastoid to lift and support the silicone so that it is flush with the undersurface of the bony remnant and support the cartilage. This will optimize the depth of the new middle ear cavity and minimize scarring as well. While doing this maneuver, it is important to keep in mind the position of the stapes and be gentle as not to dislodge or sublux it. Prior to reintroduction of the Kerner's flap, I am drilling a lateral tacking hole so that I can grab some of the soft tissue which serves to support and drive the Kerner's flap position to the most medial extent. First, I will make sure that the Kerner's flap is in good position, overlying the graft. A forovicryl on a small needle is ideal for performing this tacking maneuver. I then use a 3-ovicryl to tack the center of the postauricular wound to add additional stabilization prior to packing the external auditory canal. Using a nasal speculum, I introduce a number of strips of antibiotic-soaked umbilical tape to support the reconstruction and to optimize the diameter of the external auditory canal during healing. Once I am satisfied, I will then close the remainder of the postauricular wound as per routine. The patient in this video had a large cholesteatoma that was removed. The eardrum was reconstructed with thin-cut sheets of cartilage, and I used an intact canal wall procedure. I am looking through an ear speculum. At this point, I'm measuring the location where I need to access the mastoid and get into the middle ear through the posterior tympanotomy so as not to disturb the recreated eardrum, which has healed very nicely and is solid. I use the upper third of the incision and place a small retractor. I open the mastoid, and during the first stage of the procedure, a silicone sheet has been left in place which helps support the position of the cartilage and the graft for the new eardrum. Here you can see that there is a movement of the stapes and a good movement of the cartilage graft that is healed nice and flat due to the placement of the silicone. I am estimating the distance and the tension that I need to place the prosthesis between the superstructure of the stapes and the undersurface of the new eardrum. I use an alto style adjustable prosthesis made by Grace Medical because I can expand it even once it is in place in the middle ear. Using the angled picks, I am estimating the size that I need to cut the prosthesis. The prosthesis has small ball notches that slides through a Teflon sheath in order to adjust the size. Titanium is a very biocompatible material, so it is very useful and safe. I'm adjusting and feeling in this case that the tension is a little too hard, so I will shorten the prosthesis just a bit more to get it into proper alignment and position. I will trim it down to a slightly smaller size. I always try to make it just a little bigger initially, check the tension, and then reduce it to the optimal size and safe placement. Now I am lifting it and putting it on top of the stapes and then adjusting it into a good angle so that it is nicely snug underneath the new eardrum that has been created with a good thin cartilage support. Using a straight pick and an angled pick, I then hold the prosthesis stiff so it does not go medially down and injure the stapes, and then expand the prostheses one notch so that I have a nice, good tension and good position. And given that the prosthesis is in a good firm position, I typically return the patient to full activities without limitations, especially when a partial is used with an intact stapes superstructure. Now here's another film in a patient that had a more extensive cholesteatoma. You can see this is the view with an endoscope through the external auditory canal. Required a much more complex reconstruction without any normal or reasonable residual tympanic membrane. The tympanic membrane reconstruction is intact, and this patient, due to the extensive disease, has a lot more fibrous tissue in the middle ear because there was a lack of considerably normal mucosa in the middle ear. So in this case, I am using a laser to debride a fair amount of the scar tissue that formed around the silicone. When there is a relatively good mucosalization, the silicone doesn't create such a dense capsule in the middle ear, but when you have to remove a lot of the normal mucosa on the promontory, you do get this dense capsule formation, not just in the mastoid, but also in the middle ear on the promontory. So a laser can be used to trim this down. Despite that, you do see that in the lower part of the middle ear, there is a lack of a capsule. So the capsule is still limited over much of the region where the promontory or over the oval window region where the mucosa was abnormal or removed from the extirpation of the original disease. Here I've identified the stapes superstructure carefully, atraumatically with the laser, and you can see in the distance that there is a relatively good space in the middle ear and a good ventilation around the eustachian tube area. Now the endoscope is useful in these situations because you want to look beyond just what is visible through the posterior tympanotomy with the microscope to rule out any recurrence. Now I'm going to show you the reconstruction, but first let's take a look. So now we're taking a look. There is the eustachian tube orifice. There is air there, and there is some reformation of mucosalization. There's the promontory, and you can see the undersurface of the cartilage graft, and you can see nicely into the middle ear and the hypotympanum, and we don't see any recurrence. So now we're going to perform the reconstruction with a PORP, given that we have a normal, intact, and mobile stapes superstructure, but we're going to check its position with the endoscope. So here's the endoscopic view. I've lasered and cleaned up the undersurface of the cartilage. Now I'm going to check there's the mobile segment of the cartilage to make sure that we don't put the head of the PORP under the annular bone. It's a little more shallow middle ear space than the previous case. So I'm putting it in first, just as I did in the past. Make sure it's not too small. So now I've got it in position, and then we're going to check, and it seems pretty nice. Seems pretty good. Now we'll take a look at its position on the undersurface. So you can see there I'm feeling the edge of the bone, and there I'm feeling that the PORP is contacting the undersurface of the cartilage. And I'm just going to move it just a little bit ahead to improve its visibility with the endoscope. And now we're happy with that position, and we'll pack the middle ear with some gel foam, with some steroids in this case, because we want to minimize new scar formation. In this video, I will demonstrate the ossiculoplasty technique using the natural incus. This patient has a discontinuity of the incus and the stapes due to chronic ear infections. You can see here that the incus is not connected to the stapes, and there is a large amount of surrounding inflammatory disease. I have already completed a mastoidectomy and removed the incus. Now we are cleaning up any inflammatory debris, and now I am palpating the stapes superstructure to see that it is intact and mobile. Here is the tensor tympani tendon, which connects to the malleus to give support to the malleus when I interpose the sculpted incus between those two structures. The yellow line denotes a segment of the long process which needs to be removed, and then the body of the incus needs to be foreshortened so it does not have excessive mass or weight and fits nicely in between the stapes and the malleus. Notches are created so that the incus sculpture will fit and hold in position between the stapes and the long handle of the malleus. Now I am shortening the incus in the region that will sit on top of the stapes. Now I am removing some of the bulk mass of the incus. And now I am lowering the profile so that the incus is not excessively high and allows for a good connection between the stapes and the malleus long process. An incus interposition is a very stable reconstruction because it is less subject to erosion due to its natural formation and shape as a natural ossicular bone. I am placing it in position first before any tympanic membrane reconstruction, just to be sure that the size and the contacts are correct. Here you can see how it sits nicely with good mobility between the stapes and the malleus left in position. I am using both a posterior tympanotomy view as well as a transcanal view. Now we are looking through the posterior tympanotomy. Now I have completed the initial stages of the eardrum reconstruction and then placed the incus underneath the malleus, which already has a fascia graft in position. I surround the incus with absorbable gelatin material to prevent it from falling or moving out of position. Once I have it nicely secured, then I will complete the eardrum reconstruction or tympanoplasty.